So we haven't actually bonded yet as a patient, so we're just kind of semi-attached. So what things have you had done before?
My lips.
Your lips. What have you had put in your lips?
Juvederm and Restylane at different times.
Okay.
Regular.
And when was the last time you had anything done?
Probably 5 years ago, to the lips.
Okay.
Tear troughs.
Mm-hmm. Yeah, you still got some stuff in there.
A little bit, yep.
Yeah. Okay. And then what else have you had done?
For fillers, that's it.
For fillers, surgery. What, have you had any surgery done?
No.
Anything done to your nose?
Nope.
Okay.
Thank you.
So no secrets you're sort of hiding here?
No secrets. No.
You could tell us at all?
No.
Okay. No cheek implants, chin implants?
No.
No foreign bodies in here anywhere?
No.
Okay. So how the other thing I didn't talk about when I talk to my consult patients is I ask them a couple of basic questions. One is, do you draw or paint?
I do when I'm at work with patients.
So you are artsy.
I'm artsy, yeah.
Yeah. So I draw and paint, and so for me, the visuality of patients is really, really crucial. Mm-hmm. So do you decorate your own house?
Yes.
And buy your own clothes?
Yes.
So if the answer is no to any of those, then you've got an issue with patients having the visual eye. So just quickly here, let's find us a mirror there, Lorraine, right over there. So just forget these people that are invited guests here. Mm-hmm. And what are the positive things about your face? What have people said that are nice about your face?
Cheeks, eyes, and lips.
Yeah, that's very good. I think your cheekbones are awesome. I really like your eyebrows. Like your eyes are spectacular. Shouldn't have the baggy eyelid tendency. Jawline's good. So what things would you like to see better?
I'd like to see my nasal tip go up a little bit.
Okay. Now, did you know that before you came today, or is it something you've been focusing on?
No.
So who has the droopy nose? Is that your mom or your dad?
Dad.
Because it's quite a dominant trait, and with time, it gets a little worse. Now, just say January, February, March, April. January? Say January, February, March. April. As people animate, you watch. She moves the tip of the nose down a little bit with animation, so she's activating the depressor septi a little bit, but not a lot there. And so let's just have a look here before we measure you a little bit. Clench your teeth here a little bit so you get headaches.
Sometimes.
Yeah, because she's got a little temporalis enlargement here, so it's giving her a little wider bitemporal zone here, Arthur. She's a little wide here. And even though it's not a big issue, it's a little bit. And then clench your teeth. Yeah, and so your masseters. And you know you got masseters? So let's just feel here. Clench. So have you had them treated before?
Yes.
When was it last treated?
A year ago.
Okay. And how successful was that?
Partially. It wasn't that successful.
What happened?
I didn't keep up with it because I had injected myself.
Oh, yeah.
I'm too busy.
In the rearview mirror, you're a Mercedes or what?
No, at the office. But I'm
okay.
too busy.
Okay.
And I don't like the way the corners of my mouth downturn.
Okay. So let's just clench here a little bit, just to look here a little bit. Yeah, she's got the deep one that goes in the normal zone plus the shallow one combined. They're pretty aggressive. So are you breaking teeth?
No, I clench.
You're grinding them off, though.
Yeah.
Yeah, she's clenching and grinding both here. Now open your mouth and close. You're clicking, too. Uh-huh. Yeah, so you click mostly on the left side, so you're chewing mostly on your left side, it looks like. Yeah, okay. All right, so those are just things to think about here a little bit. So what other things would you like to see better here?
Corners of my mouth.
Corner of your mouth, yeah, and your nose.
Here.
Mm-hmm. Okay.
Maybe a little bit on the cheek, just a little bit.
Yeah.
Just a little bit.
You could a little bit.
Yeah.
Okay, we'll skip along here just to make things go along here smoothly. Did I get my calipers? Over here. Just hand me those calipers there. Just the regular ones here. No, that's too long. This one, that one. Oh, that's good. Didn't bring the other one. That's fine. Yeah, excellent. That's good. Okay. So, what do you think about her forehead here? High or is it low? So she's got a high forehead, and that's not good or bad as we've been talking about. It's just her. So how do you wear your hair? Down. Yeah. Her brain just tells her that. Sometimes you will see people walking around with this high forehead and their hair all the way back, and you just kind of turn and your eye can't help but look because it just looks a little bit distracting. So you can always do all kinds of. In fact, if you go online now, there's amazing designs for hairstyles with brows that are a little too high. So you can get quite creative with that. So if you just keep your eyes open, I won't stick you. I'll try to keep this away so the camera can see. So that same intercanthal distance is pretty basic here, guys. So you want to keep that. That's your basic measurement. So that should be the distance between her brows. And it's pretty well bang on. For the right one is perfect. The left one, she's got about 2 millimeters that are off that your eye doesn't quite like. You look straight ahead like this and look like that. You'll see it's just a little too far medial, but it's subtle enough I wouldn't fuss with it. And then that distance, the intercanthal distance, should be the width of her nose and the maximum volume of her lower lip. So the phi part, this 1.618, should be the width of her brow. Let me just make sure this didn't move while I was do-si-doing around here a little bit. Yeah, that moved a little bit on me here. Okay, and then that should be the length of her brows. And the brow is a little bit shy on the tail side here, and you could always instruct patients a little bit how to make that line up with the corner of the eye with the nose, with the tail of the brow. And then this length of the brow should be the height of her forehead, pretty well mid-pupil. And her brow is high, so that's genetic. That's your mom or your dad's side.
My dad.
Well, dads can take it. They get blamed for everything. So that's not a big deal. You just have to learn how to disguise it. And then that length of the nose should be the length of the eyebrow from the eyelash zone right from. And her, it wouldn't make a difference where you measured it because there's only about a millimeter difference. So her nose appears a little bit too long because of just the way the nose meets in with the radix. But it actually is pretty nice. It's the challenge with her nose is the nasolabial angle, which we'll measure in a minute here. So her apex of her cheek should be that length of the brow from the corner of the eye, from the medial canthus out. And her apex is really quite nice here, Arthur. We'll draw it in a minute here. And that should be the width of her lips here. And the chin, I like this measurement because it shows you where she's starting to lose a little volume in the corner of her mouth down to her prejowl sulcus here. And so we'll just draw that in fairly quickly there. Hand me one of those brown eyebrow pencils while you're right there. Okay, so we'll just have a little quick sketch here. So we're going to use this little eyebrow pencil from the corner of her eye to her mid-tragus. And Arthur draws his up a little higher, but the reality is it's not going to really make much difference at all in our mound of where the cheek mound is, the malar mound. And you can draw the circle after or before, but it gives you a good visual idea. Open your eyes there, Elizabeth. So right to the mid-tragus, down to the corner of the mouth here, and across, and straight down. And it just becomes intuitive that you draw this. Okay, now look in them up like that so you can see. So what side of her face is fuller? This side's a little fuller. It's pretty even, but this side is definitely a little bit fuller. And that's just the nature of the cheekbone and the biology of faces being uneven. Because each side of the face are definitely not twins. They're siblings, except for the lips that we've talked about a little bit there. So if you look, let me just have a little, this is good, just a little tip here. So you can use a little normal saline. You can use anything that's a little bit of a liquid here on the top of her nose so you can just see reflected light and look and just see how straight that nose is because it's got a little bit of a wow to it, but we may not be too fussy about that. So I think what I would suggest, Arthur, is we just maybe get her submalar part of her cheek here a little bit and lift up the lateral commissure marionette, prejowl a little bit, and her chin. Straighten that out a little bit. This jaw angle is actually pretty good. Have you got a white piece of paper there anywhere? Right over there. Hand me that piece of paper, Lorraine. And let's just have a look here. Okay. So let's just have a look at her shadow here. Just lean forward a little bit like that, okay? And turn a little bit like that. So remember, faces are all about the balance of light and shadows. And I think she's not a wrinkler, and she's not really a sagger. She's a bit of a deflator and a few little contour issues, and that's it. And then we'd straighten out her nose as well. We'll lift up that nose. So let's just measure that. So any guess from the audience here? What's her angle of her nose? Normally in Caucasian women, it's 95 to 110 degrees, this angle I'm talking about here. Any shout outs there? 80? You might be right. We'll just measure it here. I'd say it's about 85. So measurements are all about everything we do in life, really. If it's not measurable, we make it measurable. So her nasolabial angle is at 85, just as I suspected. We want to make hers about 100 to 105. So remember that. Yeah, remember that. That's 85. And her lips, I don't think I would do much with her lips there. They look really quite good. So Arthur? So he'll probably take you through upper third, middle third, lower third of where her issues are. But we definitely want to lift up her nasolabial angle.
Look straight ahead if you don't mind, Liz.
Yep. And we may do her, so we don't forget, we may do her Botox last for her masseters here. We'll draw that out. See, she's got that deep one there that she's clenching on. You can see, you can watch her as we're just talking back and forth. She's got that deep one that's got this band that goes right up. And that deeper one is smaller and stronger and wraps underneath the mandible. And that's what's given her the clicking. Because it puts so much pressure.
Okay. Thanks. I'll do a little bit over here. So I'm just looking at a couple of the things that what I'm trying to do, and I hope you don't mind, Liz, is to try to fill in some of the gaps that perhaps we didn't cover yesterday.
Sure.
Okay? So, to me, something that's very important on people is the shape of the face. What's her shape, guys? Square. So she's squarish. That's what Ken pointed out, is the fact that probably reducing masseters would help her a little bit in slimming the lower part of the face. But I'm going to try to do a little bit of hocus pocus here and see if I can make her face look a little more oval with a very small amount of product. So, one of the things I'm going to want to do on her, looking straight ahead, is perhaps to give her a little bit of brow elevation, but creating a peak. Now, there's two ways that I can elevate a brow with filler. I can elevate a brow with filler, as I showed you yesterday, by putting product into the temple and giving it a splay. Or you can put product onto the orbital rim over here, which is a safer zone, okay, because you're on the orbital rim. And you can put product in there that will go ahead and to contour the brow and give it a vertical lift, okay? So I'm going to try to do that. You can do that with cannula or with needle.
Yeah, I use a cannula.
I'm going to use on one side a needle, one side a cannula, so you'll see a little bit of the difference in between the two. We're going to get her hair back. I'm going to take out a BD2 syringe. I love to do it for these types of things. I want to use a product that has, okay, it's not a lot of depth over here, so I want to use a product that's a little bit stiff and has some good cohesivity to it at the same time. So, and nothing that's going to actually show too much. I'm using very, very small amounts of product. So what I'd like you to do is to load this up with, what do you have that we're pointing to? Sure. Give me define. Why not? Let's see if we can put it through a BD2. I'm curious myself. Okay. You can use refine or define if you want to use a little bit of the product over there. We could use, I like to use Volift, which you guys call the Volure over here quite a bit. That's a very nice product also to use. And I'll use it straight up just to see what we can do with it. Okay? So I'm going to try to give her a little bit of a peak, and I'm going to try to ovalize her face. I find that her OG curve, and when we talk about OG curves, those are S-shaped curves, but I find that the OG curve can be a very deep S or it can be a very shallow S. The shallower S's is more masculine. The more curvaceous is a little more feminine, not too much. So I'm going to go ahead and see if I can hit that apex to be able to give her just a little bit of a boost, a little increase over there, and give the face a narrowed look and a more of a V-line look. She has a narrow chin to begin with. Otherwise, I would actually inject the chin and try to make it even a little more narrower to give her more of a heart shape. But she is already has a little small chin over here. So I agree with Kent that I think that, trimming down the masseters is going to be a key issue on her. Okay? If you do that and you start to see a little bit of jowling that occurs over there, you take up the slack above in the upper part over here. Don't go back where the masseter was. You just took down the volume over there. Take up the slack with a little bit of that technique that I showed you over here. Okay. It's a bigger BD. That might be a little bit of a problem to go ahead and inject. Let's see. Nah, I'm okay. We'll work on it. Okay. Let me have a little bit of cleanser, please. Thank you. So, what I can do over here is I can use a cannula or I can use a needle. When I just do an eyebrow elevation by itself, I use whatever I have really that's available to me right off the bat. But cannula can definitely go ahead and contour an eyebrow properly. I look for where I want to have the peak and I stay lateral to it because what I'm trying to do is elevate this part of the eyebrow over here. I feel for the orbital rim. You're going to feel a small little stick, a little pinch. I'm down on bone. And I'm going to inject probably somewhere less than 0.05, maybe even 0.025. Okay? And I'm going to do another little injection just on bone over here. Sorry about that. And I'm going to give her again. I haven't even used, there was about 27 little bars over here. I'm now down to 22. Good. Thank you. Small little amount. And we're going to hold a little pressure.
Now, talk about, before you go on, talk about the position of her brow structure versus orbital rim and the position of the promontory and its importance in brows.
Okay, this is what I was going to do right now. An eyebrow in a female starts at 0.618, so you'd use the large end of the calipers over here, and the smaller end of the calipers will show you the height, but it should start about at the level of the orbital rim over here. Typical eyebrow in a female comes 10 to 20 degrees upslope. A male is more like 0 to 5 degrees. So 10 to 20 degree upslope to the peak, all right? The peak is about 2/3 along the way. It's actually the intercanthal distance along the way, or a line drawn from the base of the nose through the outside of the pupil that comes up and hits that over here. In a male, it's a line drawn from the base of the nose through the outside of the iris. A male peak will be a little more localized laterally. The tail of a female brow should always be at least at the height of the medial brow or slightly higher. Okay? You don't want this. That's kabuki, right? You want the tail of the brow to be slightly higher over there. Now, why is this perhaps going to work? Which it has, okay? Okay, you see how the tail is kicked up? This is called can't call it a swift kick in the tail, but I guess it's a quick kick in the tail, right? Why has that happened? Think about it. The promontory is sitting over here. Okay, guys, I'm going to throw this question out to you, so I want you to be ready to answer. The promontory is sitting over here. I've put product on the promontory, okay, on the orbital rim, that is pushing the brow, projecting it forward, that skin over here. Imagine a boat that's going through the water and creating a wake. As the boat goes through the water and creates a wake, it forces the water this way and this way. So whatever's above my projection is going to go up. If you were to try to do this on me, where my brows are very tautic, if the brow is in an unfavorable position like this, and you put product over here, as I put the product in and it forces forward, which way is the brow going to go? Down. Correct. So if a patient comes in with a lower brow that's a flatter brow, and you'd love to be able to put in your filler, but it's not in an advantageous position, what can you do to put the brow into an advantageous position? Can't hear, guys. Come on. How do you lift it? Toxin, right. So you're going to go after the vertical fibers of the orbicularis over here. Patient's going to come back 2 weeks later and her eyebrow is going to be in a better position. Then you can underpin it with your filler. What's going to happen in 4 months? The toxin is going to wear off. The brow is going to come back to its unfavorable position. And now your filler is going to make the brow look worse. Right? So what do? Can't hear you. Deep. I'm hearing all types of things. When we talked about this back, called underpinning the brow, was actually, I think, way back in 2001, Kent. When I look back at our 2001, 2003 in that area over there.
2003.
We didn't have the products that were the long-acting products at the time, so I said, well, why don't you just put in a product that would be timed to go away around a 4-month period at the same time as the toxin and retreat everything. That's the way I thought back then. It was wrong. What's the easiest thing to do? You tell the patient, do you love your brow? She says, yeah, I love my brow in that position. You're going to say, well, you know what's going to happen in 4 months? The toxin's going to wear off and you're going to look even worse. Oh my God, what do? You come back in 3.5 months, just because your toxin's wearing off, and I'll retreat you with toxin. How many of those patients miss their appointments? 0. Okay? So that's what you do. Okay, let's get your head straight a bit over here. That's it. See that little bit of elevation that we have on the brow? Look how her eye looks a little more alert, a little more awake on that side. Next issue that we're going to do, we're going to move quickly along over here. She has a pretty good cheek apex over here. I'm going to show you how I mark my cheek apex. It's just a slightly different than Kent, but we're very close in what we do. But there's more than one way to skin a cat, as they say. I draw a line from the alar groove to the top of the tragus. Top of the tragus. So I imagine a line that comes across that does this. Okay? Then I grab the lateral orbital rim. I take the mid portion of the lateral orbital rim and I draw a plumb line that goes straight down. That is where I want my light reflex to be. If we take a look at her face, it's very damn close. It's just below it over here. This is where her most projecting apex. Does it make a difference? Does it make a difference if we move the apex 1 centimeter? Let's find out. Can I have a cleanser, please? Here's my caliper. Let me see how close I am. Usually pretty close. Let's see how close I am in the measurement over here. We're going to measure the inside of her eyes. We're going to rest this right down of it. Look at that. Okay? Let me turn it around here. Okay? Sorry, I moved everything over here. Let me measure that. Here we go. From the medial canthus, that is exactly the 5 position. So if you have a caliper and you're handy, you can just draw that line and see where it intersects. If you don't have a caliper handy, just grab the orbital rim, find the mid portion of it, and drop it down. For a male,
go.
Male is down and in.
Down and in. It's like a baseball catcher calling for the ball down and in.
Let's show that.
So the apex is less subtle, and it's down and in a little bit by going to the medial part of that orbital rim.
Correct.
Medial part.
See? For a male, if you want to feminize a man, you're going to put your apex over there, and it's going to make him look like this. But for a male, you go from the inside of the orbital rim and the base of the nose to the mid-tragus, and you're going to get a position that's going to be somewhere around there. Yeah. And that's still 1.618, but on the curve, on the sweep. And so a male's cheek would look like this, and a female's cheek would look like that. So do you understand that, guys? So it's down and in. Let me have the deep again. We're going to go with the deep, the define, sorry. Yeah, it used to be called Emerville Deep. That's why I'm calling it deep. But it's called define, Restylane define. I'm going to clean this area, show the procedure the respect that it deserves, which means you got to keep it clean. When I inject patients, I say I'm not injecting a device, I'm not injecting a filler, I'm injecting a relationship. You're going to have to live with this product for the next 1.5 or 2 years. We're down on bone. You good? 0.25 of. I'm injecting slowly. I'm going to release off the bone and lift slightly. I'm putting in that second scoop of ice cream on top of the cone so that it sits one on top of the other. I've used a small amount of product, and the skin just sticks up like that.
Is your product diluted?
No, this is pure. I'm going to go pure today to show you guys that you can do stuff with pure product too. Straight up. Okay? I used over there 0.15. 0.15. Let's get your head straight. Turn your head. Which side of the face? She's a little bit in shadow. Which side of the face is starting to look narrower? The side that I just injected. Okay? That's the idea behind the injection. Let me very quickly tell you what I forgot to tell you yesterday. When I'm dealing with the mid part of the face, I inject the lateral aspect of the face before the medial aspect. I work laterally. If you ever see Maurizio talk about his CK points, he always talks about CK1, 2, and 3. He works lateral as well. There's a reason for that of injecting laterally. And that is because this is tiger country. And sometimes if you go ahead and you treat the lateral cheek, you don't have to treat the medial cheek because you get an effect over there too. And if you can avoid going into that area, I'm very happy not to dwell in there. Okay? So the idea over here is that we treat laterally and I treat higher before I treat lower. So if we were to look, can I have a pencil please for a second? If we were to look at her cheek and she had a deficiency, which she doesn't, she's got beautiful cheek over here. In fact, we'll mark it out afterwards. But let's say she had a deficiency that looks something like this. That she had a gap, that she needed more volume. Right? I would plan my little bolus injections. Guys, I'm outside the lateral iris over here. Remember I told you that's my definition mark point because I know medial to that is where I'm going to get into that tiger country. What's my injection depth over here? What is it? Either superficial or deep, correct. But I will choose deep more often. Why? Because the deep fat, the SUF, doesn't move. It's attached to the bone. It's there to be able to coat the bone so that the orbicularis muscle can glide over it. The superficial fat, all the superficial fat compartments of the face are mobile fat. Can you smile? See how she drives her cheek up when she smiles? If I was to put product into that cheek, she will drive it up, and especially if you're medial, she'll look like Cirque du Soleil. She's going to be all puffy in the front, right? So you want to put the product deep and allow the skin and the superficial fat to glide up over the top of it, okay? So that's the idea. And I would treat 1, 2, 3 because 1 is higher than 2 is higher than 3. If I had to do it this way, if her deficiency was like this, like a nasojugal groove that we said we're going to try to find one, I would treat 1, 2, 3. If you treat the first one, look at the effect you're already having on the second area. You're already getting a little bit of lift on the second area because everything in the cheek is suspensory. If you understand that, you'll use less product when you get here and you might not need any product here. And I'm a miser when it comes to product. I want to try to keep as much product as I can in the syringe so I can treat other areas. The more areas you treat, like in toxin, the better the effect. It's the opposite with the lower mouth, with the lower face. The lip doesn't support the chin. Look, we're going to inject her to see what we can do to elevate this corner of the mouth, okay? But we're not going to lift up her chin with her lip because her lip is mobile. So what we have to do is we have to build structure from below and elevate this way. So my sequence of injections is 1, 2, 3. If I'm going this way. If I'm filling with the cannula over here, I start the flow of the product right away and then push everything up. You want to have a foundation to be able to have the lips sit on that. The reason the corner of the mouth turns down is because of the volume loss over here and the lip drops into the cavern that's caused by it. Okay? So, let's clean this up just a little bit. Take her dark marks off. I want to inject the lower part of her face because she wanted her lips turned up. Good. Another thing that we can do, let me take a look at you and we'll see what the story is. Look at me straight on. Let's try this little trick. I'm going to try to show you little, like I'm saying, I'm trying to fill in little gaps over here. Let me have something to clean, please. Thank you. There's something that I refer to as the Cain triangle. Michael Cain talked very often about filling in the lateral canthal region with filler. He does a beautiful job of it. And there's an extra little bonus that you can get. I still have the same product in my syringe. We're talking about be fine. It's a little bit thick for what we're doing, but I think we're going to be fine. This is a minefield of small veins. Try to pick an area in between. Stay on the bone. Small little stick. We're down on bone. We're going to put in a small amount of product again, especially because it's a product that has quite a bit of oomph to it. It's going to cause a teeny little bump. We're going to pull out, nice and gentle. And now what we're going to do is we're going to massage that. And we're trying to create, for lack of a better description, and my plastic surgical colleagues are going to jump all over me, I'm trying to create a lateral canthoplasty over here, a lateral canthopexy. As we age, what happens is our orbit opens up and the 5 to 10 degree upslope from medial to lateral canthus starts to flatten out. And you lose that beautiful 5 to 10 degree slope, which is very youthful.
It's almost always worse on one side.
Correct. So if you go ahead and put in a small amount of filler over here, what we're trying to do is we're trying to give her not an Asian look, but we're trying to create a little bit of a 5 to 10 degree upslope. I was checking to see if she was missing it. Let's see if we have it now. Open your eyes. It feels weird because it's numb. I want you to look into the camera over here. Okay? Look at the difference in the two eyes. Okay? Do you see what I've done? Does it show? You're looking. Okay. What have we done? Especially in patients who have a little bit of what we call scleral show on the outside. You see how the eye is more rounded over here? And that she's showing a little more of the white of the outside? This eye over here now looks like it's tilted up a little bit like that. Okay? It's a more youthful look.
How come you're showing them all our tricks?
I've got to show them everything because it's a
the other
small
way,
little thing
like,
to do.
As Arthur knows very well, sometimes you do this exactly the same way you do the tail of the brow. Sometimes you lift at the same time to create that structure. Then it just lifts that lateral canthus a little bit better. But that's a really good little trick.
Is this a fresh
It's a subtle little thing that makes a big difference.
Lower part of the face, I say start below, up. I'll tell you my story with that. Okay. And the lower part of the face, I'm going to put something on bone because I want it to be solid. Anything I build above it, I want it to have solid foundation. We're going to continue with the same product. Okay? We're going to continue with the same product. And we're going to put in, here we go. I look at the marionette zone because it's not as Kent has told us, it's not a crease, it's not a fold, it's more of a zone. Sometimes there is a permanent crease that's in it. I'm picking my spot on bone at the mandible. The artery is back over here. The mental foramen is up over here. So I'm safe to go, or safer to go down on bone over here. I stabilized my hand. Notice the way I'm always stabilizing my hand with the patient. You would be amazed that you're about to inject a patient, their cell phone rings, they turn their head away from you. So you have to go with them. Okay? So you go with them. This way you're stabilized. You can see that. Okay? I'm making a little... See what I do when I do this? People were watching and asking me about this. People say it's distraction because you're actually causing movement in the same place that you're putting your needle in. And according to Melzak's theory, that means that the movement will be interpreted first because it travels along myelinated thick fibers versus the pain fibers that are delta fibers that are unmyelinated. They get there second, but the brain's already processing something and says, can't handle two things at once. So that's part of the deal. But the other part of the deal is look what happens to the skin when I do that. Do you see the way it comes up? So if you do it and you simultaneously do it like that, okay, it decreases the pain of the needle going in. Small injection, 0.1 cc's. I'm almost at 0.1 right now. I'm going to release off the bone by 1 millimeter and lift the skin and put my second ice cream bowl right on top of the first one. And I'm going to stop. Two things happen. If you look from the patient from above down, you get projection. That's number one. And it's rare to have any type of bleeding, maybe a small amount, because when you lift the skin like this, she'll bleed now because I just put a little bit of chlorhexidine on there, and that's going to take away the little fibrin clot. But if you lift the skin like this with your needle, when you pull your needle out, the skin drops down back over your initial puncture site and it tamponades the bleeding. So you get much less bruising. We didn't bruise anybody yesterday, I hope. Any of the people we did yesterday get any bruising? No. I'm asking for the ones who actually had the injections done, because good. So that's the idea. You bruise them, you lose them. Right? You pain them, you won't retain them.
And then if they make them look like a weirdo, I don't remember.
If you make them look weird, you will be feared.
Feared.
That's right. It's only 3 rules that you need when you're holding this. Okay. My second injection, I could go right down to bone again, but the mandible is curved like this. That's going to mean I'm going to need a lot of product to go ahead and to get the projection that I need. I'm also going to be touching the depressor labii inferioris muscle with the lidocaine. She's going to have an unusual smile for half an hour. I want her to be able to go out and meet her friends immediately after we finish so they can see how radiant she looks. So my depth now for the next one is half. You see that? Most of my needle is sticking out. I elevate the skin so that I take the stress off the product, and I put in a small amount of product, maybe 0.05 or 0.1. I'm a little, I was going to say a little prick, but I'm known to be that, so that's all right. I'm a little bolus injector, okay? We've really gone away from flooding the face like we did before. We understand it's foreign material, that you don't want to flood the face with foreign material. As we go up now, I'm starting to get into the area where the teeth are. I don't want to put product onto the teeth, and I told you that that artery that can sometimes hang down like a hammock is no more than 4 millimeters deep. So my injection is getting even more superficial. Look, it's only a third of the needle that's underneath the skin. I'm lifting, and I'm putting in a small amount of product again. Slow injection, watching there. I'm looking in between my fingers to see what's happening. And when I get to the corner of the mouth, I have to be just subdermal. Last injection here. There it is. Lift up, and we put in a small amount of product over there. Good. What have I done? I've built 4 pillars over here, okay, that the lip can now sit on. And here's the trick of the day. We have to give them all our tricks? Yeah, let's give them all our tricks. What do you think, Kent? Oh, let's hold this one back.
Yeah.
It'll drive them crazy. What was he talking about? 2 things that women have above their neck that men don't have. What is it? That's number 1, higher intelligence. You're absolutely right. Higher intelligence, we bow to the smarter sex. There's no question about it. What's the other thing that women have that I haven't been able to find on a man? This thing. Come in close, guys. Okay? Look. What is that?
Triangle.
See that triangle over here? See the way she breaks? You can't make a man's lip break like that, and they don't usually develop that break over there. I used to think that it was because of the way women talked, that's the way they were doing it. They were looking at their husbands and going, and then they were getting that little sort of crease over there. So you know what I started doing? I started looking for those in people who had a feminine way of talking. In my gay male population patients, I would try to see if I had that same type of thing, because they have a way of expressing themselves sometimes in the way that they purse their lips that perhaps is a little more feminine, but I couldn't see it on any of the males. Why is that? This is the evidence of loss of structure of the upper lip. As we get older, we lose the structure in our lip, but men have an advantage. What is it? Hair follicles.
Rebars.
They're rebars. They're pylons that are in there. So if you're going to try to raise the lower lip, okay, by doing the type of technique that we did, you feeling a little numb?
Yeah.
Okay, that's normal. If you're going to try to raise the lower lip, what's going to happen is the upper lip, because it's lost its structure, look what it does. It's going to flop over the top of it. It's like a hammock. That's like a wet noodle, I guess is what you want to call it. So you have to structure that area. I'm going to withdraw a little bit. You're going to feel the small little stick. There, it's in. Now my needle is just in the subdermal area. I'm advancing the product ahead of my needle so she doesn't feel much. And I'm still using the same product. Sometimes I even put in Voluma over here if I'm working with Voluma or if I'm working with Velour. And what I'm doing is putting in a small structure over there, very, very gentle, to stiffen that part of the lip so she doesn't break as much. Let's put your head straight again. Look what happened. First of all, what is your end goal for the corner of the mouth? Look at the first increase in vermilion show here. Do you see that? People ask me, how do you flip the outside of the lip up? The way you flip the outside of the lip is not by putting product into the red part of the lip, but by putting product into the white part of the lip that acts like a garage door and flips the lip out. See how she has more vermilion show on the outside? She also has vermilion that's coming right to the edge of the corner of her mouth, which is what we want on the upper lip. So what's the end point over here, guys? You're going to be filling, and you can see that she said, remember, she didn't like the idea. Look at the difference between the two commissures here and here. Do you see it? Okay. This area is filled in, and she has a slight little... How old are you?
I'm 50.
Wow. They don't look 50 like that where I come from.
She's a Quinn.
I grew up in Vermont.
Oh, you grew up in Vermont. That's why.
That's why there's no sun.
No sun. Lots of snow.
Yeah.
I'm a stow skier, so I know that deal.
There's no sun.
There's no sun. Lots of powder, though. Okay. So if you take a look over here, okay, let's focus back in on the lip because we're going to talk about that. Anytime you're doing anything, you have to know what your aesthetic destination is. You don't inject until the syringe is empty. You have to have an end point in your mind of what you're trying to create. Okay? In a patient, she's about neutral. She's coming about this. Should I continue to inject and give her a slight smile? Should I have left her a little bit downturned, or do I stop at neutral? How many people think I should continue to inject and give her a smile? How many people think I should leave her at neutral?
Yes.
And not leave her down? So here's my way of thinking, guys. And again, it's not right or it's not wrong. It's just my quirky way, as Kent always tells me, a very quirky of way of thinking. If she was in her 30s, or all the way up to maybe even her early 40s, whatever, maybe in her 30s up to her late 30s, if she certainly was in her 20s, I would leave her a slight smile because it looks normal. If my daughter, who's in her 30s or just hit her 30s, is walking down the street and has a slight smile on her face, it looks perfectly normal because she hasn't got kids. She hasn't got people who are driving her crazy. She shouldn't look dour. She should look happy. She should be enjoying life, right? Isn't that the whole idea? But if my wife was walking down the street, and I won't say her age, but let's say she's a little older than that, and she had a constant smile on her face, people would look and say, what the hell is she thinking about? Doesn't look normal. So I think when you're a little bit more mature, that you should be smiling responsively. But when you're young, you can always have a little bit of a smirk on your face, and it looks cute. So I'm stopping over there. I'm using this little part over here as well. And that's the little trick to do the injections of the lower face with a teeny little bit of product over here. I haven't used a syringe of product on her yet, guys. Okay.
I have doctors come to my clinic for those teaching days kind of thing.
Yeah,
and
those
we'll say,
preceptorships, yeah.
are you doing this just for your teaching day, or is this how you do it? This is how we do it. We don't change.
This is how we do it. That's an old song.
Yeah, so this is how we do it. It's not done as any special entertainment for
Sending
today.
some love to my bros out there. Okay, here we go.
You ever do the marionette zone with the cannula?
Yes. You know when I do the marionette zones with the cannula, Kent, describe your technique of how you do the marionette zones with the cannula. We can do it on this side if you like.
Yeah, you could.
Okay. Why don't we do that? Can you put a 27 on this, please? Cannula? Go ahead.
I usually start from the bottom of the jaw angle here, and I usually use the 27 or 25 inch cannula, or 25 to 27 gauge, and a usually 30 millimeter, inch and a half kind of thing, to 40 millimeter cannula. And I'm in the sub-Q zone, but I start here, and I'll inject just along deeper, right on top periosteum here, and then I come up in the sub-Q like Dr. Swift has already done here, and then I'll get above the red of the lip as well, and fan out this whole little zone. But very similar to the needle technique, but just a little different layering method.
Right. Because in that situation, what you're doing is you're creating structure. You can do it. I mean, you can do it this way too, and I don't mind going ahead and doing it. It's a little different than the way that I do it, but I'm being Kent right now. So he dressed me this morning, so I have to follow what he says to do. Right?
It was scary.
It was scary. It was. Okay, so where would you like me to make my access point? I do it sometimes from here and I fan down, but I want to do it his technique.
Yeah, I would measure. See, let me see your cannula there, Lorraine. So you'd measure this so you end up with you're above the red of the lip here.
Okay.
So then you sort of mark that little zone there.
So you want me to go in about over here?
Right there. Perfect.
This is a 17. This is a 27 gauge. Oh, you made it a little challenge. 27 gauge trocar, 27 gauge cannula. Stretch the skin out. Now you lose the hole, so you can't find it. You wait a minute. It's going to show itself. There we go. Okay. And Kent, you want me to start from below, I presume?
Start below.
Okay, so I'm going to go ahead and give you a little pinch over here. Here's my depth. Are you happy with that? Take a feel.
Yeah. Let's see. Yeah, very good.
Look how much product I have in my syringe. I have 0.2 in my syringe. And you're going to say, why did he even start with that? I should have started with a new. I probably should have, but we're going to see. Technique is back and forth.
You go back in the same hole.
Yeah, well, I'm going to show you how I don't go back in the same hole. Because I'm a bad boy.
So you just very gentle, just anterior grade or retrograde. He's now more in sub-Q. He's a little shallower in this marionette zone.
Okay, you come back, you're almost out. Yeah, there we go. There we go. So here's my depth over here, Kent. Are you good with that?
Yeah, I'm very good with that. I like that.
All right. If you like it, then I'll continue to inject.
That's good. Yeah.
All right. Guess what? I'm just about out of product here, which I am. Let's see if we can do this. Yes, we can, because she's good.
No, you're no fun.
I don't like the struggle to find that hole again, so I just do that. And I reconnect. And we continue. Good. Yeah, that's why my cannula is constantly moving, and that's why I'm pretty much in the subdermal plane over here. But that artery could be sitting right underneath my cannula right now. Just because you're using a cannula doesn't mean that you're completely safe. That's why there's constant movement. I inject with cannulas like I do with fat. Fat, I'm constantly moving my cannula as well. Okay? So I'm up in the corner of the mouth now. You can actually see the little poke. I think that you can see that it's coming just to where the vermilion is. How you doing?
Good.
Good. Great. Now Kent's going to want me to take it above, I guess, right?
Yes.
So let's try that. I love trying new things.
Sometimes there's a little band there you have to just pop through a little bit. There you go.
Okay.
No, actually it's not going to work.
Now you see where the tip of the cannula?
Lift it up
Yeah.
when you inject.
Sure, go ahead. So I'll lift that up like that.
As you inject.
And you want me to inject like this?
Right.
Here's a little poke.
So you're getting this strut work, the same idea as the needle, and then you get that little better support. You're not trying to give her the Joker look. You're trying to give her the little, just more youthful lateral commissure.
How's that?
The only thing that yells that she's a quinquagenarian is the corner of her mouth is drooping, right?
Yep.
That's what says, I got some miles on me.
Yep.
Yeah. See, now, voila. It's very nice. Very good.
So you can do it with cannula if you so prefer. I tried to get up around there. That was the first time I've done it that way. Thank you very much.
Welcome.
My technique
He's
is
a liar.
No, I'm serious. I usually don't do it in the inferior approach, but I like it. I like it a lot. My approach is usually a fanning technique because I started to work on people in the way they smiled. Okay? And it's just a gentle type of thing that you do.
That's very good. See that?
Yeah. Okay, let me see if I got that area. Yeah, look. So you can see that she's not breaking over here as well.
It's good for a French boy.
Not bad, huh? Okay. You call it from the audience, guys. What else? What? Oh, thank you. Who said earlobes? You took away my question at the end of the day. Oh, my. I was going to ask you, you have 0.1 or 0.15 left in your syringe, and you're looking for somewhere to put it. You can always find somewhere on the face to put it. But guys, the number one thing that's going to be the biggest booster to your practice is to bury that stuff where? Let me hear you all say it. You're damn right. Why?
Nice.
Because earlobes deflate. Look what the situation is. And
she's
Kent's the master at this.
She's had these repaired,
Right.
and unfortunately it was done in a third world country with a knife instead of a laser. So, because I laser them, then there's no bleeding, and it's very tidy. So they've been repaired, and so then you can mark where you would re-pierce these. So where would you tell her to have? Where would you do a little dot and have her take her photo with her smartphone and take it to her piercer to have her ears pierced? Above the scar or below the scar?
Above.
Above the scar. So when the earrings hang down, they disguise that little crease. So, but no, you could go ahead and have these reflated.
Yeah.
Yeah, that's good. You'll like that a little bit. That's the second thing that yells that you've got, that you're a quinquagenarian, is you got floppy earlobes.
I was going to talk about this to one of the patients. I was going to talk about this to one of the patients yesterday who was wearing loop earrings or was wearing hanging earrings, and she had a little bit of a tear or a little bit of a vertical sort of pull on her earlobe. And what you would notice, and I was going to say to her, I bet you don't like to wear studs, because when you're wearing studs and your earlobe is deflated, the stud faces south.
You don't want a mini.
And they don't look that great. So you have all these beautiful earrings that you can't wear. When you inflate the ear and give it a little bit of substance, all of a sudden the earrings pop out. They're sitting forward. The patient loves it. The husbands really love it because they don't have to buy new earrings for their wives. They end up having looking like they have brand new earrings, where you can see that happening. So it's an injection really anywhere in the earlobe. It causes a little bit of sufflation, so you get this type of effect. And we can do that at the very end over here too. Can I have the Define again?
Ready if you want. We got silk in a mini.
Yeah, sure.
Right, ready to go.
Yeah, let it rip. No problem. And I'm going to do tear troughs on her. I'm going to explain tear troughs on her, and we're going to do it on the next patient, okay? Because she has product in here that I would melt out. And I'm going to use her as an example to explain to you why she got into this little bit of a problem here with the Tyndall effect, okay? So
Silk straight up.
Silk straight up. Let's turn her head to the side.
Now, the disadvantage of silk straight up in a BD2 is it flows like water a little bit. So it's better to transfer it into Easy Touch. So they look exactly the same when you just glance at them, but the lumen's a little smaller and it flows better, so the proprioception is better. So if you're using silk, don't put it in a BD2. But for here, it's fine. He's got great hands, so he can still feel it. And filling these, if you have it, it's not like pumping up a balloon or a tire. These things have little pockets to them, like a honeycomb. So it takes a few little sticks, and then you can blend it and mold it into place. And you actually mold this. You blend lips, but you mold this and get it to blend where you want it with the molding of it.
So I've used 0.1 of product so far, pure. This was pure, I guess, huh?
So how long does this last in the earlobes?
You like that earlobe? Let's take a look at the other side for comparison. See deflation? Need a little teeny bit more, huh?
Let's see.
I think about over here, guys. Would you agree? Okay, let's do it. Small stick.
Yeah, you think you'd just be able to pump those up like a flat tire, but
You good with that?
Yeah.
Just do a little massage.
it's for like my clinic is like your
Define,
clinic. It's
please,
a serendipitous thing. Patients don't come for that, but it's one of
Whatever
the
comes
things
with
like
the
the nose.
define on whatever
It's
you
part
want
of the
to come. That's
serendipitous
perfect.
experience to come into your clinic. Remember, serendipity is something nice that happens on the way to the forum. So it can happen on. You try in your clinic to make serendipity happen on purpose. So you pick out things that you know the patient will like, but they didn't really know. So it's a purposeful experience that you know ahead of time.
Okay.
I'm learning.
Learning?
I'm learning.
Yeah, it's a girl. And you're listening too. So, that's
How
what
long
she
does it
did.
last in earlobes?
Yeah,
It can last a couple of years.
probably. It lasts a really long
It
time.
doesn't last as long on the side you
There's-
sleep
there's-
on.
There's no movement. Remember the crease you had over here? Everything is gone. There's no movement in the earlobe, but some people can wiggle their earlobes, but most people can't. So there's not a lot of movement, so that product stays there for
Stays a
quite a
long
long
time.
time. If you wear on clip-ons, it doesn't last as long.
No.
Or things that you put a tight post
Depends on
on,
the
it
weight
doesn't
and
last
how
as
they're.
long.
It depends on
Yeah.
the shape of the lobe. But that's true. It varies a bit.
Small stick.
And some people eat up these products too. It's just depends on your structure of your skin. There's lots of free radicals in the skin that eat up hyaluronic. So if you have a high concentration of free radicals in some areas, then it eats it up. Smokers, it eats it up. People that have a lot of sun damage on that area of the ear is always more difficult on the left side of the ear.
Making little crunchy noises now. The needle's getting dull, but you're doing very well. I just wanted to top her up over here so we can get into talking about the periorbital region, because I think that's an area that a lot of people struggle with. Right? Okay. So I'm going to talk to you a little bit about anatomy of it so you'll understand. I used to have the same problems that everybody has, and I still have some of the times those problems, but much less now that I understand why I was getting those problems, okay? If you look at the periorbital region, the muscle that we're talking about is the orbicularis. Right, the orbicularis oculi. Well, the orbicularis oculi is an interesting muscle. It's very similar to the temporalis muscle. The temporalis muscle, because it's pulling up on the jawline, is anchored down to bone. The orbicularis, because it wants to act like a sphincter, is anchored down to bone medial here, above and below the medial canthus on the orbital rim, supraorbital and infraorbital rim. The muscle fibers are inserted into the bone, so you don't see any soot under there. There's no suborbicularis oculi fat. Okay? If there's a tear trough ligament that's located 3 millimeters or so right below that, that's very tight. Okay? So, is tear trough a deformity? Please don't use that word like I said the first night here on Friday night, because what it is really is just anatomy. You're looking at the different portions of the orbicularis oculi muscle. Okay, you're looking at the pretarsal and the preseptal portion, okay, the orbital portion of the orbicularis muscle that causes this little V like this. You're looking at levator labii superioris liquid nasa that's coming down, and in the depth of that tear trough, you will find that the levator of the lip, okay, levator superioris is sitting right down there too. So what happens is some people have fat.
Pointer.
Yeah, sure. So some people have fat that covers this, and that's why they don't have a tear trough. Some people are born without a lot of fat over there, okay, over the top of it, and that's why you don't see it. But as we age and we lose the fat in our face, it becomes more apparent and we become more hollowed. Now, as you get past the iris on both sides, the muscle is no longer attached to the bone, but the muscle now glides over what we call the SOOF, the suborbicularis oculi fat. The orbicularis muscle is shaped like an aviator's glasses. It's shaped like Ray-Bans, not the Gucci round ones. We're not talking about those. We're talking about Ray-Bans, so give me a big smile. That's why people break over here. Look at the form of the muscle right here. You can see it. Okay, she has toxin in, but even with the toxin, I'm getting an idea of how expansive this muscle can be. There's a little midline raphe over here, a little septal sort of attachment over here so the orbicularis doesn't flop down on you. But we sometimes, when we do facelifts, find the orbicularis coming all the way over here. It's a very expansive muscle. Yeah. That's why sometimes you have to double your rows when you're doing toxin over here.
Yeah, and sometimes here, we talk about the crow's feet, but generally, well, it's like crows usually look in the mirror and say, I like my face, but I hate my feet. And so it can be these little wren's feet, or it could be blackbird feet, or crow's feet, or raven's feet, or eagle's feet, or some people have buzzard's feet that go way out.
Okay.
Way out, so you have to follow them.
So here's the deal. You can inject a long orbital rim over here because it's a safer zone. The infraorbital artery starts 5 to 8 millimeters below the orbital rim, usually at the medial iris, sometimes right towards the medial pupil. That's why you'll see it in a lot of textbooks at the medial pupil, but 80% of the time it's more medial over here, and sometimes you can actually feel it. Patients will not like it too much if you go down too deep because they feel a little bit of that sensitivity right there. Some people say, my friend Claudio De Lorenzi says that if you put your finger over here and you draw an X over your nail, right where the middle part of your nail is, or your X, is where you're going to find that infraorbital artery foramen. As I mentioned to you when we were doing the anatomy, the nerve and the artery are coming out at 45 degrees, so there's a little hood of bone over the top so that if you come from the side, the hood of bone is protecting you when you're injecting. But we're now talking about tear trough over here. So a lot of people do the injections on bone with cannula or needle. If you're trying to go on bone over here medially, you cannot get under the muscle. Okay? It's impossible. You can't get under the muscle because the muscle's stuck to bone. So where's your product going? In the muscle. Correct. If you try to correct an entire tear trough over here on the medial aspect of it by putting product on bone, you're really putting your product into the muscle. A lot of these products don't like to be in the muscle. Okay? And we're using thinner products over here. Silk doesn't like it. Volbella doesn't like it. Even your Bellotero doesn't like it. Okay? What happens is when you close your eyes very tight, you act like a sphincter. You close like this. You don't close like this. You close like that because you're pulling everything. Close your eyes tight. Look how she pulls her eyebrows and everything medially here because here it's attached, here it's gliding. If you want to inject on bone past the medial iris over here, you're in the SOOF. You're under the muscle. That's perfectly fine. But over here, you can't put all your product there because it's like squeezing a tube of toothpaste. She's going to blink 1,200 times an hour, 20,000 times a day. When she blinks, she activates that orbicularis muscle. As she squeezes and squeezes, she's squeezing that tube of toothpaste from the middle. Inside that tube of toothpaste is your product. It can't go here because it's tethered. Where is it going to go? It has to go down to here. And that's why you always see the Tyndall effect right here. Because what's happening is this over a period of months is they're bunching up the product. What is Tyndall? We talk about it, but do you understand what it is? Tyndall is reflection of blue light. Blue wavelength light is the longest wavelength. It's why the sky is blue, except if you're in Shanghai, in which case it's always gray. But if you're in normal places where you look up at the sky, it's blue because of water vapor in the air. Water has Tyndall effect. Tyndall is related to depth. If you take a look at the ocean and you're standing by the beach and you want to find seashells, the water is clear. It has no bluish look. But if you look out into the deep ocean, and for those of you who are sailors, you know that the darker the blue, the deeper the ocean. That's because of the fact that the blue light is bouncing off. Right? So anytime your product starts to thicken up over there, which is why you want to use a super thin product, you'll get a Tyndall. You can create a Tyndall with water. Okay? So you don't want the product to thicken up. So you have to lay the product in thin. But I just told you if you put too much product in the muscle, it's going to squish it into a ball and she's going to get the Tyndall, which she has over here. So my approach to the tear trough now is a bilamellar approach. It's a 2-layer approach. I put little teeny drops into the muscle because I don't care if there's a small amount. And then I go over the top of the muscle with the cannula. I'll use a 27 gauge or a 30 gauge cannula because the product, as Ken told us, is super, super thin. And if you press it too hard, you're going to get a thick amount and you're going to get that bluish Tyndall. So you have to be very light on the gas pedal over there, and I'll coat over it. This is similar to what we're doing in plastic surgery when we do blepharoplasties. We understand now, in the old days, we used to tear through the muscle. We used to do all types of crazy things to get to the fat. Now we work on the fat from behind by doing a transconjunctival approach. We work on the fat behind the middle lamella, the muscle and the septum. We work behind it, right? Either to sculpt it or to remove it. Some people are still doing to redrape it, whatever you want to do. And then you do something to the skin over the top, whether it's a laser treatment. We use erbium or fractionated CO2 lasers, or you do a pinch blepharoplasty, whatever you want to do, but you leave that middle lamella, the functioning part of the muscle, alone. Do the same thing with your filler. Put your filler down deep, and then go over the muscle and let the muscle do what it's supposed to do without squeezing your product. This has been the biggest change for me in periorbital work, because of the fact that I'm not getting those patients coming back at 5 or 6 months with the bluish ball. I couldn't understand it. I said, I did such a beautiful job. Why are they coming back 5 or 6 months later? That's the ticket. We're going to try it on hopefully the next patient, and hopefully we'll do a little bit of supra or infrabrow hollows on the next patient as well. Any questions about that? You can do this with cannula or needle. When you try to go with cannula to the medial portion of the tear trough, I told you the muscle is stuck down to bone, so your cannula is going into the muscle. It's going scraping along the orbital rim. It's a little uncomfortable. That's why I still prefer when I go deep to use a little needle every now and then, but you can certainly use a cannula. You can flip your cannula around and do the same treatment over here. Correct?
Right.
Right. Here, you go under the muscle into the soothe. Yes?
Could you talk about how you would go about dissolving her?
Okay.
And when you would bring her back?
Sure. People say, by the way, when you treat tear troughs, if you want to take a nice little tip back home again, don't go for perfection. Leave them wanting. It's the most difficult thing. As a surgeon, when we're in the operating room, the most difficult thing is to sit on your hands and do nothing. You have a bleeder or something, you pack it, you wait. You got to wait 5 minutes so that you can basically stem the bleeding to be able to go back in and stop it. You have to stand there for 5 minutes and do nothing. It's the worst thing. Doing nothing for a tear trough, having a patient go out with a beautiful face, okay, having the patient go out with a beautiful face and looking like she still needs a little bit of stuff in her tear trough is very difficult. You're going to want to go ahead and treat it. Don't. Because more often than not, those patients will come back 4 or 5 months later. HA loves water. Even though you might go ahead and blend it 50-50, it's still looking for a little bit more water. She will go out and have a glass of wine with her friends. She'll go out and cry at a movie 4 months later, 3 months later. She'll get swollen underneath over here. She'll have a very spicy meal or go for sushi with soy. She'll get swollen over here and the product is waiting for the water. He grabs it and then she starts to puff. And you say, I don't understand it. I did such a perfect job. And she's coming back 6 months, a year later, and she's swollen. By the way, if you don't melt this out, how long is this going to last? Just about forever. I've seen patients. We saw a patient that we were injecting this morning that I said, you had something put underneath? She said, no, I didn't. I said, you had something? She said, no, I didn't. She said, I've only been injected here and here. I said, let's go back. She said, oh yeah, 6 years ago, 7 years ago I had something. I said, I still see the product in the Tyndall. Okay? That's why if you do it poorly, you're looking at it forever. Why? People say, well, don't worry, just do it to perfection. And in the odd case that comes back that looks a little full like this, you can melt them down. What's the problem with that? I love using hyaluronidase. It's the number 2 product I use in my practice now. Try that one on for size. I'm busy melting everybody that I'm seeing rather than injecting them. So what's wrong with using hyaluronidase in the periorbital region? What does hyaluronidase do to hyaluronic acid? What does it do? It breaks it down to what? Not sugar. It is sugar, but what's it breaking it down into? Little sugar particles, but most often, what is it breaking it down into? Water. It's turning the product into water. She's swollen here because her lymphatics can't handle whatever water she has now. You're adding in volume of hyaluronidase, and then you're changing the product there to water. What do you think is going to happen to her after you inject hyaluronidase? She's going to get a festoon like you've never seen. And that takes a week or so to go away. And the only way to get it, they have to sleep with their head up and put ice compresses and everything. And the patient calls you every day and says, I look worse, I look worse. You say, hang in there, it's going to get better, it's going to get better. So here, if you hyalase something in the cheek, you don't care because it's deep. You don't care if there's a little bit of extra fluid. She'll resorb it. But here, the lymphatics are being completely overwhelmed. So I would prefer to undertreat and treat up than to have this happen and try to melt it down and then have her calling my office every day about a festoon on her cheek. So that's my little tip to you. Okay?
Let's try to treat this before we have to quit here.
Yeah, go ahead. Pick your product, Kent, and the syringe.
I would use. Can
we use the Define that we have already?
You can use Define or Refine.
You wanted me to put it on a BD, or you want to use it on
Define on a BD?
Perfect.
And we got 0.25 there for you. But the only place I measure is this little zone here, so it's a 0.25 amount.
Right.
I have a question.
And we've cleaned that really well. Hang on for a minute here. We're gonna do this, and then we can.
Yeah, we're going to
Answer
inject
that,
a lot
so-
more rather than
So
talk.
this is really important. Few little steps to understand how you do this.
I have a,
So we've measured it, but it's been so many hours ago, I forgot how
Yes.
what the measurement was.
it was 85
It was
degrees.
85 degrees. Okay, thank you.
Okay.
So
Want
and
me to
then,
take a vertical
and then you
approach?
you want to make sure that she's not one of those rare patients that has the nasal spine that sits way up high, because as Arthur will tell you, those you can't lift up.
Right.
So if you've got, and hers is perfect anatomy for that, you can lift it up nicely.
Okay. How you can tell if a nasal spine is overly prominent is that most people have a natural C shape to the location between. I'm going to lift your head up here a bit. So you get a nice. See that nice little C between the nasolabial angle? In a patient that has an overprojecting nasal spine, that C becomes almost an I. You can see it like this. See how it tense up? And they get this straight line over there, and you can feel it. It's something that we usually address in rhinoplasty when it's really overprojecting. So
Now watch
I'm
carefully
going to try
how
to
he
keep
does
her,
this.
Going to lift her nose up like
Stick
this.
here. And let the nose fall on the needle there.
I got to feel the bone to make sure that I'm in
There.
the right place. That's pretty much the bone right there, sweetheart.
There.
I'm sorry.
That's good.
You all right?
Yep.
Okay. I'm going to start
And
to
then he's going to
inject.
lift up the nose so he has a place to fill. So if you don't lift up that nose, then you don't have a nice space to reflate and fill and contour.
I can tell you that the product won't come out of my little needle because I'm actually probably my needle's sitting in the periosteum and doesn't want to stretch the periosteum, so I'm coming a bit off it over here, and I'll lift. Where am I looking, guys?
Let me hold this up so you can.
I got it. It's okay.
Okay, good.
So I'm looking. Skin of where I'm injecting, and especially over here because the columellar artery is running in the membranous septum. It's not on the bone, but it's running in the membranous septum. How you doing?
Good.
All right. I'm injecting slowly, and I'm checking over here to see if there's any blanching up over there, and we're good. This is Define, but you can give them a list of
You
things.
could use Voluma. You could use Restiplan. You could use Volift doesn't lift as well. And you don't necessarily go by your G1 prime kind of thing, because I find that
How you doing?
like Voluma for me is one of the better products to use, but this is good as well. But you can't use something like Silk or Bellaterra, and it just doesn't lift because you got to have some lift. You don't want to have lateral spread. You want to have this.
Resty Lift would work quite well too.
Now we're talking.
What you actually can do, and you can see how the nose is starting to tilt up a little bit, is that sometimes it's amazing. I'll tell you quickly about my
Let me just measure this now. So we went from, see how fast your Portia was here.
She was 85
It was
before.
85. So we've gone from 85 to 110, which we wanted her to go to.
Okay.
So 85 to 110 in 10 seconds there.
It will give you a super tip break, which is what we look for sometimes, because you're actually sort of rotating the tip up a little bit. If I wanted to elevate her tip a little bit more, I would lift the tip, let it fall back down onto the nose. See where the split intermedial crura is, as we call them? These are the domes over here. This is the medial crura. Okay. This is what we call a genu, or the knee of the medial crura, which is this little angle that we have over here. She has a genetic split here. Mm-hmm. You got to talk to patients about that because you can remove that, but it takes away their family heritage too. So be careful about that. Okay. But if you want to really elevate a tip, and I picked this up from reviewing photos that Kent had, he showed me a patient that he had done panfacial toxin on, and I took a look and measured, and I found out that her tip was a good 2 or 3 millimeters elevated. And I said to him, did you inject a depressor septae on her? And he said, no. And I said, well, why is that tip up? He had knocked out her bunny lines, which is the transverse portion of the nasalis muscle. But the other portion of the nasalis muscle is what's called the dilator nares. It's a muscle that starts from the piriform and hooks around over here that people can sometimes flare their nostrils, but it's a tip elevator. So if you put in 3 units over here and 3 units over here, or Kent likes to use a little more, 4 or 5 units over here to knock off the bunnies, and you go after the depressor as well with your toxin by putting in 2 or 3 units midline over here, okay? So that's, let's say, about 8 or 10 units. The only muscle that's left that's active in the nose is that elevator of the tip, and you'll create a Spock tip. It'll actually lift up the tip somewhat. So combining what we just did with a little bit of toxin would be ideal on her to really rotate a patient that has what we call a drooping tip. Okay?
How would you inject the toxin? Where would you inject right here?
Very slowly.
Very slowly.
Yes. No, you can inject it directly. I used to inject it from the side. It's a little more sensitive from the side, but you can inject it direct over here. I'll give you a couple other quick little stories about the nose. You saw us do nasal valves yesterday, which is beautiful. You saw us stay midline to do dorsum. You saw me do an injection of the tip where I did it like this and allowed the tip to elevate. There's one last thing that you can do. We did that this morning in our little private session. Patient had a canted tip like this. You see them sometimes where they're just a little bit off? Mm-hmm. On the side that the nose is pointing towards. So you see that it's pointing towards you? This is called the leading edge of the septum right over here. You can put your finger on it. It's the wall on the inside. The membranous part is the part that moves. At that leading edge of the septum, you go in with a little needle over here, use a product that has a little bit of oomph to it. That's G prime. In my language, it's oomph. So you can use Voluma, you can use a product like Ultra or Ultra Plus, you can use even Restylane, whatever. It has a little bit of stiffness to it, and you just start to inject over there. And what you're going to do is you're going to mimic as if you're putting in a piece of cartilage to straighten the nose. And as you inject, you're going to start to see the nose do this. And that's what we saw this morning.
Yeah.
Okay, this guy had a nose that was a little bit twisted like that, and we ended up making him perfectly straight. So you can straighten noses out by doing that a little bit, and that will also last for a good 6 to 9 months. I do that sometimes on patients who are waiting for rhinoplasties who haven't got the patience to wait for the surgery, so I'll go ahead and inject a little bit over there. You've been fantastic.
Thank you.
Thank you.
Now
And nobody commented on my 2-colored gloves? I was trying to make a fashion statement. I told you Kent dressed me this morning. Look. Yeah. We ran out of my purple gloves.
Let's do our masseters here too. Let me draw this out here.
Sorry.
Before you want to do our masseters?
Oh, go ahead. Yeah, I'll put her gloves back on. Sorry. Mark it out where you want me to inject her, sir.
May clench.
It can, yes. It's a dilator nares, and some people call the dilator nares the other lobe of the transverse of the nasalis muscle. So you can't. That's okay. He'll take the call later. So do you think that it might actually flare the nostrils? I mean, sometimes we put toxin in over there to keep the nostril from flaring. How are we doing time-wise? We're okay?
We need about 5 more minutes.
Yes. Then you can actually cause a little bit of a droop of the tip, so be careful. So you may have to use a little filler to counteract that.
Yeah, Botox.
Okay.
Botox. Yeah. So we better make some up here.
How do you make the nostrils more narrow is by injecting onto the piriform over here. The injection of the piriform. Did I do one yesterday for you guys? Yes, I did. The injection is down towards the commissure of the mouth. You're on bone. As you inject, what happens is as you start to lift, this is what happens. And you can narrow the nose down. I do that very commonly in Asians and Afro-Americans as well. But you have to be careful over there because in Asians and Afro-Americans, in 1 in 5 of them, what's sitting in there? Facial artery. So you have to go down to bone. You must make sure you're touching bone. But if I saw blanching of the glabella, then my initial reaction would be, okay, because we are talking about pretty much blanching of the glabella you're talking about, or blanching of the columella? I'm sorry, what was the question? Both. Yeah, if I saw that, I would withdraw right away. Give a little massage to the area, because in the nose, and this is when somebody asked me yesterday, I told you I had a venous problem. I'll tell you very quickly as he's marking her for the injections over here. I would massage the area because they're end arteries. It could be occlusive on the outside, external compression, and if it doesn't whiten up right away, I hit them with the hyaluronidase. And I put the hyaluronidase right where I put it over there or anywhere else that I see blanching. So here's my quick question for you guys to think about when you're going for lunch. Patient came in to see me and said, I've had surgery on my nose. It was obvious. Over-reduced dorsum. Over-reduced, like a real scoop. Okay. And she said, can you do, I don't want to go through surgery again. She said, so Is there anything that you can do? I heard that you do this little wizardry with fillers. I said, sure I can. I took a history. When did you have your surgery done? I had one surgery. It was done, 7 years ago. I'm not happy with the result. I said, okay, fine. So I marked the patient up and I'm saying I'm going to inject her midline on the dorsum, right? Isn't that where you're supposed to inject? Midline on the dorsum, because the dorsal nasal arteries are parallel, but they're off the midline on either side. I get out my product. I take up my little BD2. I inject midline on the dorsum over here and I fill her up like this. I turn around to get my ultrasound gel to do the massage, and I turn back and the entire nose is purple. The entire nose. I'll show you a picture. It's purplish red. I'm looking at her and she said, is there anything wrong? What are you going to say? I said, well, you're developing a hell of a bruise over here. It doesn't make sense, I'm saying to myself. I know that I went in the right location. So I looked at her and I'm sitting there. I said, Arthur, you were in the midline. You were where you were supposed to be. You were down on bone. So I said to her, how many operations have you had on your nose? She says, 9. She told me 1. I told you, when you do injections through a scarred bed, all bets are off. Here's the problem. When you repeatedly operate in rhinoplasty and you're constantly elevating off the skin and doing your work and setting the skin back down again, you have now disrupted the anatomy there so significantly that maybe there was one major feeder going into her nose and one major vein coming out. And now it could be a situation of not intravascular, but compression. Maybe you compressed the artery or the vein. Here's the problem. I didn't see her blanch because I had my back turned to get my ultrasound gel, so I didn't know if I had compressed the artery or the vein. They look the same. If you ever see a flap that gets into trouble, venous or arterial, they look very similar. How am I going to make that distinction? Because you're treating it differently. Sure, you're going with hyaluronidase, but if the artery is compressed and there's not enough blood getting into the nose, am I going to give her warm compresses or cold compresses? Warm. I want to open up the vessel to give her warmth. If the artery is flowing in, but the blood can't get out, so I want to stop the artery from putting in too much blood and congesting it, what am I going to give her? Ice. But I didn't see it. What am I going to do? Hyaluronidase for sure. What else am I going to do? I have to give her everything in my armamentarium to make her better. Massage. What else am I going to do? Am I going to give her ice or heat, guys? Come on, tell me. What do you do to find out if it's arterial or venous? Stick a needle in. People have told me that because you're going to see if the blood is dark, it must be venous, and if it's bright red, it's arterial. Guess what? It can come out green. I'm so panicky, I wouldn't know the difference. And who knows? Blood might be a little darker. Is that really red? Is that dark? What am I going to do, guys? Sorry? Capillary refill. Absolutely. You take your finger. I told you this is one of the best. You take your finger, you press it on the nose, and you see how quickly it takes to refill. I pressed it on the nose, and it was rapid. The blood came back in right away. What does that mean? It was a venous obstruction. So what am I going to give her? That's right, I gave her ice. But if the blood return was very slow, what would I have given her? Great.